Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. In this presentation, we are going to be talking about your heart. Yes, indeed, your heart. I'm a cardiologist. I've been in practice for 40 years here in the Houston area, and we are going to focus upon what are the different causes of chest pain. How do we take the history? How do we do the examination? How do we arrive at a diagnosis of chest pain? And what do we do with that? So let us focus on the main presentation. A chest pain can be happening from a variety of situations. But let's take, for example, we get an executive sitting in the office having, "Ooh, I'm having chest pain." Then you get a little anxious, you get a little nervous, you get a little palpitations, you get a little sweating, little small sweating in your forehead, and your assistant comes and looks at you and says, "Boy, you look pale. What happened to you?" "I don't know. I'm having some chest pain, kind of feeling like a tight. Must be that Mexican food or the Indian food that I ate." No, you're not going to take a chance. You're going to call the ambulance, 911. Well, the ambulance comes, they take you to the emergency room, then they roll you into the chest pain unit or the room, give you an aspirin, hook you up to the oxygen monitor, hook you up to the EKG, and they start talking. But let's talk about first what are the different things that can cause chest pain. 30% of the time or 40% of the time when people go with chest pain, it is not even related to the heart. That should be reassuring. There are exceptional conditions like people having really a heart attack who can be having the same kind of chest pain. There are people who can have pulmonary embolus, which is not commonly seen unless you have some underlying medical condition. That can also give severe chest pain. I mean, that's like 10 over 10 chest pain with heart attack or pulmonary embolus or aortic dissection. So those are rare conditions. We're going to leave them aside. The garden variety chest pains, as I said, 30-40% of them are not even related to the heart. So just relax. Take it easy. Take a deep breath in. Close your eyes. Breathe nicely and let the doctors and the staff members do the work. The chest pain could be coming from the chest wall, from the rib cage or the muscles. Just follow the white arrow here. Or it could be related to sometimes the inflammation of the sheath that covers your lungs. The inflammation of the sheath that covers the lungs. That's known as pleurisy. It hurts. When you take a deep breath, it hurts. When you breathe, it hurts. When you cough, it hurts. That's sort of a typical of a pleurisy. You also may feel a little feverish with the pleurisy, and you may feel kind of like you're just worn out. Same along the same condition is the pericarditis. That's the inflammation of the sheath that covers the heart. It's generally seen in younger population, like in the 20s or early 30s, and it's related. It's a virus, non-specific inflammation of the sheath that covers the heart, which is known as the pericardium. And when you get that one, there is some irritation, and it hurts when you bend forwards or when you move, and it kind of comes and goes. SPASM is the typo here. Anyway, that's the esophageal spasm. Again, this is an exceedingly rare condition where the esophagus goes into spasm, like it becomes like a corkscrew, and that it causes squeezes. It kind of mimics the heart pain, though. And even the pain is relieved by nitroglycerin because the nitroglycerin relaxes the smooth muscle. So it would be very hard to find out what is causing esophageal. If the pain is coming from esophageal spasm, sometimes it may be related to acid reflux that can irritate the esophagus and create the spasm. But esophageal spasm is an exceedingly rare condition, but that's one condition that can give rise to. And if you have like a hiatal hernia or acid reflux constantly, you're burping, then it can irritate the lower part of your esophagus, which is known as the inflammation of the esophagus or esophagitis, and that can also give rise to a chest pain because it is sitting right behind your heart, and you can have sort of pain coming and going. Sometimes it may be related to food, sometimes not. Gastritis, if you have a gastric ulcer, it's in the stomach, but you may feel the pain in the chest, and it may be related to food. It may be relieved with antacids. And that's something you have to think about. And most often, you eat a spicy food or you eat something really like jalapeno or something, then you can have an indigestion in your belly that can go up your chest and mimic like this pain is coming from your heart. Hiatal hernia is a very, very good example of pain related to your food pipe and the stomach that can mimic heart pains. Because the hiatal hernia kind of bulges into your upper chest through the diaphragm, and because of the acid reflux, it gets inflamed and it is also pressing on the heart. So it can give rise to pain, intermittent pain that may sound and feel like heart pain. Well, gallbladder attacks. Usually a gallbladder is in the right upper quadrant here. But what happens is when you get a gallbladder attack, the pain radiates to your right shoulder, and along the right shoulder, it travels along your chest wall. Then you begin to think like, oh, is this cardiac pain? Man, it kind of feels like something I've never felt before. Yes, of course, you don't get gallbladder attacks every day. So that can be the sign of a gallbladder attack. And the other way also, when people are having chest pain, we are focused on heart, but sometimes they could be having an acute gallbladder inflammation. And if we ignore that one, then while they are being washed in the hospital for heart, their gallbladder could rupture, and it has happened. That's why I'm telling you this. Pneumonia. Pneumonia is another cause. Of course, people with pneumonia will have fever, they will have cough, they will have congestion, they will be short of breath, they may have like bronchi, all kinds of stuff. And the rare conditions which I talked about are pulmonary embolus. They are more serious conditions, so we're going to just leave that aside for the time being, because by the time we do all these tests, the preliminary tests, the emergency room doctor will know exactly what they are dealing with, because the presentation with these more serious conditions like heart attack, pulmonary embolus, and aortic dissection, they are kind of grave situations where people will be sweating, their blood pressures will be low, their oxygen levels will be low, they are feeling dizzy, they are sweating, they are kind of very weak, and the electrocardiogram may show some changes, and of course the tests will show changes. Okay, now we know what are all the different things that cause chest pain. How do we kind of, we need to streamline this. This is too much of a laundry list to be thinking about chest pain and what is causing it, because you got 5-10 minutes to examine a patient and move on to doing what needs to be done. So, of course, careful history is important. Is it related to diet? Does it hurt when you take a deep breath? Is this pain constant or does it come and go? How long does the pain last? Does the pain go to your shoulders or to the arms or anywhere else? Do you get sweating? Do you get palpitations? Do you get dizziness? And all these things help us to streamline as to what is causing your chest pain. Of course, we do the physical examination. We listen for heart sounds. We listen for heart murmurs. We listen for any rubs. If it's pneumonia, we're going to hear some extra crackles on your chest examination. So all these things help us. Blood tests are very important. We check your blood count. We check your chemistries, kidney function, and most importantly, the heart enzymes known as the troponin. If the troponin is normal, then the chances of you having a heart attack at that moment is very slim. It may go up later on, 6 hours, but that's a different story. Now we're going to do an electrocardiogram. If the electrocardiogram is perfectly normal, and if your blood enzymes are normal, at least we know we are not dealing with an acute heart attack. You got it? You're not dealing with a heart attack. It may not be even cardiac pain. It could be from the food pipe, it could be from the hiatal hernia, it could be the acid reflux or the food that you ate that you're not supposed to eat. Then we do a chest x-ray to see if there's any evidence of like a pneumothorax. That's another rare condition where there's air leak into the chest cavity that compresses the lung and that gives rise to a pain. You can't even breathe. Oh my gosh. When I take a deep breath, it hurts. I can't breathe. The X-ray can immediately show you pneumothorax, which is an emergency. Actually, there you have to put a needle and put a tube to drain that air from the air cavity pleural cavity so the lungs can expand and then decide what we need to do. Chest x-ray, I told you. And occasionally we have to do a CAT scan. CAT scan is extremely useful in patients with dissection or if they have pulmonary embolus. But not everybody needs CAT scan. I told you 30 to 40% of the people who come to the emergency room may just get a thorough history, examination, blood test, and EKG and a chest x-ray. With this, we should be able to sort out is this cardiac, is this stomach, or is this anything in the lungs that is serious, like pneumonia, or anything else that you can see on the x-ray, like a lung mass, if you're an older person. If all those things turn out to be negative, chances are it is not a serious condition, and they generally prescribe you like an anti-inflammatory agent. If there's some tenderness on the chest wall when they press it, you get some soreness in your muscles. It may be muscular pain, so let's try this antacids. So those are some of the things that we do. There's another condition which I forgot to mention, that is costochondritis. Occasionally, you get an inflammation of the joint that joins the cartilage and the rib cages. And that gets inflamed. That's known as the costochondritis. And usually they respond to anti-inflammatory agents like ibuprofen or even Tylenol. So those are some of the things that we keep in mind when we are doing. So ladies and gentlemen, hopefully if you are experiencing chest pain, you should not panic to start with. You should get serious. You should not ignore it. You should get focused and try to relax and get some help. Go to the emergency room, let them check it out. If it is not serious, but still, when you get to age 40, you need to start taking care of yourself. You need to worry about your blood pressure. You need to worry about your blood sugar levels. You need to worry about your weight. 40% of the people are overweight. We need to worry about our stress level. We need to worry about our cholesterol levels. If all these things if any one of these are abnormal, then you need to see your primary doctor, you need to see a heart specialist and get those things in order so that hopefully you don't have to make another emergency room visit. Thank you so much for watching this presentation. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. I have numerous educational videos for people who are concerned about their heart, be it chest pain, be it irregular heart rhythms, be it a valvular heart disease, be it needing a stent, be it needing bypass surgery. We answer all these questions, and if you have any questions that needs to be answered, just put it in the comments. We will do the research, find the information, and bring it to you. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. I will see you in the next video.